from Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about reconstructive surgery after mastectomy. Our guest today is Dr. Jarrett Schultz, a plastic surgeon with First Physicians Group. Dr. Schultz, thank you so much for joining us.
Thank you for having me.
Do most patients who have a mastectomy elect to have reconstructive surgery as well?
So many women do elect to have reconstructive surgery after a mastectomy, but it really varies widely based on which patient population you're looking at and geographic area. Nationally, the rate of reconstruction after a mastectomy is actually around 40 to 50% of people.
In your experience, would you say that that's true of patients who have mastectomy for cancer treatment versus those who have preventative mastectomies?
So when people have preventative or prophylactic mastectomies, just to clarify what that is, that means that they don't currently have cancer that needs to be treated, but they might be at high risk of cancer either because of a genetic mutation or maybe like a strong family history. And so they're having a mastectomy to prevent that in the future before they even have cancer. In that patient population, I do say they tend to have more reconstruction in my experience in that situation.
What are the main types of breast reconstruction options available today for patients who do elect for that?
So there's two main types of breast reconstruction. One is implant-based reconstruction, which is the more common type that we typically hear about. And it's reconstruction with saline or silicone implants, the same that we use for breast augmentation. And then the other type of breast reconstruction is called autologous reconstruction, or you might hear it called flap reconstruction. And that's when we use tissue from somewhere else on your body to reconstruct a breast mound.
So what are the advantages and disadvantages for each procedure?
So a good advantage for an autologous or flap reconstruction is that it's your own tissue. You don't have to use a foreign body. So it looks and feels a bit more natural than an implant, and it ages with you nicely. It matches well with the other breast if you're not having a mastectomy on the other breast. And one of the main advantages is in the setting of radiation. So sometimes when people get radiation for cancer, it can damage the skin and the tissues in the area that sometimes make it hard or even impossible to do a reconstruction with an implant. In that case, it's very advantageous to use a flap procedure because you can bring in tissue from somewhere else on the body that's not been radiated and sort of replace that tissue that's been damaged.
Is everyone a candidate for flap reconstruction, or do you sometimes have to go with an implant?
So not everybody's a candidate for flap reconstruction or implant reconstruction for that matter. Everybody is a little bit different. In general, you need to have enough tissue somewhere else on the body for us to be able to use to make a breast reconstruction. And one of the disadvantages is a very complex procedure. It requires microsurgery, and so usually requires a microsurgeon to be able to perform it. And because of that, it's a very long procedure and requires to stay in the hospital and a longer recovery time. So in patients that maybe aren't in the best health otherwise, it might not be the best option for them.
How do you help have these conversations with patients who don't know which direction to go?
Yeah, it's tough because everybody's situation is different, and what's right for one patient isn't necessarily right for another, or their goals may not be the same. So that's one important thing to take into account is what are the patient's goals and preferences for their reconstruction? Is it somebody that hates the idea of an implant? Then maybe a flap reconstruction is better. Is it somebody that wants to get back to work and their family as soon as possible and have no other surgery besides on the breast? Then maybe an implant reconstruction is better. So everybody is very different. So we take into account their goals, their preferences, their overall health, what else is going on in their life, their preoperative anatomy. All of those things come into play when we're choosing which reconstruction is best for them.
And when we talk about the flap procedure, is there one area of the body where typically you go to first for those flaps?
Yeah, so the gold standard is what we call the DEEP flap or the DIEP flap. And what that stands for is the deep inferior epigastric artery perforator flap. So we call it the DEEP flap. And that is taking tissue from your lower abdomen, so basically the skin and fat from the lower abdomen. And we basically take that tissue with that blood vessel that I just mentioned, and we transplant it up to the chest, and we hook it up to another blood vessel. So now that piece of tissue lives on the chest. And again, it's your own tissue, so it can be nice for some patients. And that's the most common place that we take it. There are other places that we can take it from, though, such as the thighs, the butt, the back. But the gold standard is lower abdomen.
What is the typical timeline for reconstruction? Are most people doing it immediately when they're having their mastectomy, especially with cancer treatment, or are they doing it delayed?
So there's a lot of different options, and again, everybody's a little bit different. There are some circumstances where it's not really advisable to have a reconstruction at the time of the mastectomy. For example, if you have like an aggressive breast cancer involving the skin, or otherwise in poor health, it might not be advisable to do it at the same time, and we call that a delayed procedure, where you can come back, at a later time and try reconstruction. But most of the time, a lot of the times, luckily, we can at least start a reconstruction at the time of a mastectomy. And from there, it's usually either reconstruction on the day of mastectomy, or more commonly, a staged procedure, where you have like a tissue expander placed on the day of the mastectomy. We allow your skin to heal. We sort of re-expand the skin with a tissue expander, and usually come back at least a few months later to do the second stage of reconstruction, which can either be an implant or the flap surgery.
Are there common misconceptions you hear a lot about reconstruction, or what life is like after reconstruction?
I think one common misconception is that there's only one way to do it, which, as we talked about, it's certainly not the case. Implant reconstruction is the most common way, and kind of what most patients are aware of, before coming into their appointment. So one misconception is that, that's their only option, and that's just certainly not the case. There are other options, and what's, like I said before, what's right for one patient may not be right for the other. Another common misconception is sometimes people come in and think that their insurance is not going to cover the reconstructive portion of their procedure, and that's also not true. So insurance should cover reconstructive surgery. There was a law that was passed, I think, in 1998, where all insurance companies who cover mastectomies are required to cover the reconstruction portion as well. And that has no timeline on it. If you change your mind and you decide you want reconstruction later, they'll still cover it. Any revision surgeries and even symmetry surgeries on the other side, they will cover.
You mentioned all the options, and we spoke about implant versus flap. We didn't touch on types of implants, and you mentioned the silicone versus the saline. Mm-hmm. How do patients decide between that, and are there advantages and disadvantages between those?
Yeah, so you can use either, and there's different plastic surgeons that might use one over the other. Typically for mastectomy patients where all of the breast tissue is being removed, I typically recommend silicone implants. They just tend to look and feel a little bit softer, a little bit more natural than saline implants, which, if you can imagine, is sort of just a bag full of salt water. So sometimes you can see some rippling, things like that, based on your anatomy. So typically my patients will have silicone implants placed, but either are perfectly reasonable options.
Can you talk a little bit about how support systems, families, partners, friends impact the recovery process after mastectomy and reconstruction?
Oh, it's very important to have a strong support system, not even just for surgery. Obviously it's great to have support to help you through the recovery and help you out after surgery, but even just, emotionally and mental support and all of that is important, for the entire breast cancer journey. Chemo, radiation, there's so many aspects of breast cancer care that it's really important to have, people around you to really lift you up during that time.
Reconstruction is, of course, the secondary goal after getting rid of cancer in mastectomy, or preventing cancer if you're having it preventative. But can you talk about the benefits of having surgery like this done at a comprehensive cancer center like the Brian D. Jellison Cancer Institute?
Yeah, there's a ton of benefits. The main benefit of being at a dedicated cancer center is access to care and access to all the providers, which is not true of every hospital that you go to. It really is a multidisciplinary approach to all of your cancer care. So when you come to a cancer center, you have everybody on your team, you know, radiologists, your medical oncologist, radiation oncologist, the nursing staff, geneticists, you know, you have all of these resources and access to them that really helps to coordinate your care and sort of make that easier on you as you sort of navigate your cancer journey.
What advice would you give to someone who's just beginning their journey?
You know, I think when you're considering having breast reconstruction surgery, it's just really important to have realistic expectations and really try to get all the information you can about all of your options. You know, sometimes even before you go see your plastic surgeon, you know, don't be scared to do a little bit of your own research or, you know, talk to people that you've known that have had this procedure. You know, there's online support groups. There's, you know, a lot of resources, and the more information you have, the more empowered you're going to feel about the type of reconstruction that you and your plastic surgeon, you know, end up choosing. And like I said, everybody is different, and just make sure that you feel comfortable with the plan that you and your plastic surgeon come up with together. It can be sort of a very long journey. You know, the entire reconstruction process can take a lot of time, and so your plastic surgeon is going to be taking care of you for quite a while. So just make sure you feel comfortable with it.
Is there a lot of follow-up after reconstruction?
Yes, definitely. So, you know, especially during the process, you know, we talked about how sometimes we stage the procedure. There's an expansion process sometimes, and then even after you reconstruct the breast, you know, there's still more options after that. Sometimes if your nipple had to be removed, sometimes then you move on to doing a nipple reconstruction. And then sometimes if you had your nipple reconstruction, you get a tattoo later. You know, there's just so many stages, you know, sometimes to the final process. So more than likely you're going to be following up with your plastic surgeon sometimes years.
How is it decided if someone needs to have the nipple removed versus nipple sparing surgery?
So a lot of that is going to come from the surgical oncologist and whether or not the nipple is involved in the cancer, or depending how large the tumor is and how close it is to the nipple, usually will dictate whether your surgical oncologist will remove it or is able to spare it, and that would be called a nipple sparing mastectomy.
So regardless of if you're having that reconstruction right away or later, is it really advantageous to have the ability to have the plastic surgeon and the surgical oncologist under the same roof and
Yes.
talking to one another?
Yes, definitely. We work closely together, you know, day in and day out, you know, with the breast surgeons. And it really helps for them to know the reconstructive plan before and for you to know the cancer plan before. And so therefore you guys can sort of plan things out together, where the incisions will go. It's a lot of collaboration between the two surgeons, and it's very advantageous to have both of them on board before your surgery.
So before we go, is there anything else you want to add?
I think we covered most everything. You know, just to reiterate again, you know, every breast reconstruction is different. Every patient is different. Every cancer is different. So there's a lot of different options, and just I hope that everybody can get some information from this to help them make that decision.
Dr. Schultz, thank you so much for joining us. If you liked this episode of HealthCasts, please like and comment, and visit smh.com/podcast to listen to more experts like Dr. Schultz talking about the health issues which matter to you. As always, we encourage everyone in our community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.